Topbed Talk.
This piece is a panel discussion featuring Daniel Mina, Assistant Professor at the University of Toronto, and the scientists in ELLICSR, the Princess Margaret Cancer Centre, Stefan van Rooijen, the surgical resident at the Maxima Medical Centre in the Netherlands, lecturer at the First Health Innovation School, and surgical resident at the Department of Surgery at Maxima Medical Centre. Also, Gerard Danjoux, consultant in Anaesthesia and Sleep Medicine at South Tees Hospital NHS Foundation Trust, and Ken van Someren, Director of KVS Performance Limited. It's called Delivery of Prehabilitation, and it's a panel discussion. Have a listen.
Jerry, any tips for convincing patients that prehab is safe in the totality of it, as well as the high-risk patients, especially your AAA lot?
Any tips? It is safe.
Yeah.
And I think we've got a fairly robust or developing evidence base for that. If we think about just the maximal cardiopulmonary exercise tests we've all done over the years as a network, the safety is pretty well established. In our own high-intensity training before abdominal aortic aneurysm repair, there were no serious adverse events reported over a number of patients, over a number of exercise hours. And if you look at the cardiac rehab literature, so if we look at the cardiac safety profile, even in high-risk populations with high-intensity training, you're talking about a risk of a serious adverse event of about one event for every 23,000 exercise hours. So I think we can never say never, can we? But and events will occur at the population level, but we can be fairly convincing with our patients that there's a good safety profile.
Thank you.
Just to amalgamate perhaps a couple of questions for the whole panel around workforce, and can the Prehabilitation Society not start a certification program to enable different professions to perform nutrition, exercise, prehabilitation? Would that take the pressure off the system and one element of the workforce for consideration, chaps?
The issue of certification is a challenging one, and certainly within the exercise space, it comes often down to certain settings where having registration versus not having registration with a governing college, and that's not always the case when it comes to those who are providing prehabilitation, as we know. I think physiotherapy has taken a lead in this space because they are often a trusted colleague because of regulation, and they have been regulated for much longer than perhaps the exercise physiologists in some settings or the kinesiologists in some settings. But with regulation has come responsibility and credibility, and those other exercise professionals have joined the team. Creating a society-based certification for exercise professionals or otherwise is a challenging one because the legislation in the local areas at the end of the day will govern whether or not they should be working within that scope or not. So at the international level, even if it's supported by the society, I think that it probably plays an endorsing role, but I'd probably be interested in seeing what the plan would be to having a certification that is universally accepted. I think that'd be quite challenging given legislative barriers. Yeah.
Anybody else like to comment?
I think when we really want to move this further, we need to come up with a new profession, like the prehabilitation physician or someone that has another role in this full concept and really knows what we're talking about and who can define the several roles. So.
And there's also something, I think, Daniel, you put up about protected titles and regulation and safety of people. So that's a really important consideration. And
I think that we'd all appreciate in the room the importance of having protected titles for the purposes of our patients who we refer to. We would like to know that our colleagues in nutrition and medicine and exercise and psychology are credible at what they do and they have a skill set that aligns with what we would expect. And I think that ensuring that much through regulation is important, but having a title that the patient won't be confused with is important.
Great, thank you. I think this one's for you, Jerry, or everyone else that could pitch in. I think it's a really important topic as well. The topic of monitoring and the topic of, especially when you let them out in their own environment, how do you monitor these patients?
So, I mean, the home-based thing is a really tricky one, and I think we've heard a lot about that. And what we're doing at the minute is we are analysing this data in detail is pretty time-consuming, and as you all know, and we're just starting to look at the home-based data now. The home-based patients did come in for exit assessment, which I can see is part of the second part of the question. So we will be analysing the data from those 20-odd patients, and that should be available. We plan to publish the outcomes from PrepWell in due course, and that will be included. But at the moment, I don't have that exact data. But they were monitored otherwise, and that Esther would have regular contact with them on a weekly basis by telephone to see how they were getting on, see if there were any concerns. They were given, both groups were given home-based exercise equipment, including kind of physiotherapy TheraBands for resistance training. There was no discrimination with inspiratory muscle training, whether you were home-based or centre-based. So, you know, it was regular contact from the project manager. But I totally agree, we need to get better at how we actually use technology about monitoring this group, definitely.
Sorry.
Daniel, do you want to pitch in? How do you do that across the pond? Do you have any tips?
In terms of monitoring home-based, within a trial context, we're all often trying to assess whether or not there's maybe some contamination, if you want to call it that, for those who are at home, who in fact work out in a facility. But I think that what we're studying right now in our center is what defines the home. And I think that at least when it comes to exercise, we all assume, I mean, we should not assume, but some may assume, that the home-based exercise is in fact being done at home. And if you provide them with TheraBands or an exercise ball and exercise mat, then they're going to clear space in their living room. They're going to do the exercises that you prescribe. And it's going to be very convenient because they never have to leave their home. But we have a graduate student who's taking pictures of the home. And when you look at the actual space that they're exercising in, it's not conducive to a ball sometimes, or it's not conducive to a mat. Or perhaps they're a little bit more fortunate and they have a home gym and they have all the equipment that you would ever want. Or perhaps they live in a condominium and they go down to that space and they have lots of equipment, or they go to a local gym. Sometimes we need to reconfigure what we call the home. It's not always at home. Sometimes it's at a facility that's local to them. In terms of monitoring, we try logbooks, we try different apps and tools. There are great apps that allow a personal trainer, exercise physiologist, physiotherapist to drop in a set of exercises into an app on a phone that the client can then say they've done this much and how much it hurt, or how much it felt, how well it felt. But the idea being that there are digital ways to record some of this, although I think the feasibility of it in all populations is still something to be considered.
Great, thanks. So,
last question, if we may. So there's a lack of knowledge around who's available in the exercise industry as a whole. There are highly trained, competent level 4 instructors that can and do deliver prehab. So rehabilitation should be So what are people's views about the links? And we've heard about it earlier.
A colleague of mine, Karen Robb, who's not here today, I was touching base with her, but the UK, in meetings we've had previously, has a certification system that's a little bit different than some of the other places in the world. Level 4 instructors have competency and expectation certifications that are comparable to the others, but there's, as I understand, range. And I'm not sure how the local setting will try to ensure that when patients are being referred to level 4 instructors, they can appreciate that they have the competencies in place. I know that there are level 4 instructors that are delivering prehabilitation in the programs that are being run in the UK with great success, as the data has shown at this meeting. But when we look at the titles and its usage and how that translates beyond the UK, and even to patients within the UK, I think there's some clarity that could be achieved in ways that would help the patient as well as the clinicians who are making the referral.
I mean, If we take a look at that from another way, another aspect, I mean, these health trainers at level 4 are delivering community-based cardiac and pulmonary rehabilitation, management of complex patients with weight management problems and diabetics. So, you know, these things are already out there, and a lot of it is maybe about stratifying. So, I mean, one of the best examples we've heard about is from the Manchester group and how they're using the health trainers, and they've got a screening evaluation to do that. And also, you know, we've got plenty of things available in our public health systems already without having to duplicate things and reinvent the wheel. And certainly speaking to, you know, it was kind of quite eye-opening for me when I first started out on the prehab journey to see what public health actually did and had on offer. And they were our real champion partners in the work we did locally.
Thank you all, and thank you to all of the presenters.
Lee Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com, and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.